Good morning. My name is Shivani. I am a gastroenterologist at Akron Children's Hospital. About a year and a half ago, I had the privilege of starting the neurogastroenterology and motility program at the Children's Hospital. Because children with mitochondrial disorders can have problems with their mobility of the GI tract, I have been able to work with the neurology department at Akron Children's in order to help be a part of the team that helps take care of patients with mitochondrial disorders. I would like to thank the foundation for me to speak with you today about the gastrointestinal manifestations of mitochondrial disorders. I apologize that I could not be there in person, but I do appreciate everybody being very accommodating. The objectives for today's talk are to briefly discuss the role of mitochondria, and I'll make that very brief since I'm sure everybody is well aware. We will describe the mitochondrial disorders and their inheritance. We will discuss GI manifestations of mitochondrial disorders and the treatment options. So what are mitochondria? They are organelles found in almost all cells in the body. The primary function of mitochondria is to generate energy in the form of ATP or adenosine triphosphate. They also store calcium for cell signaling, generate heat, mediate cell growth and death. The number of mitochondria per cell varies. For example, red blood cells do not have any, but liver and muscle cells have hundreds to thousands, which would explain why the liver and muscles can be severely affected in mitochondrial disorders. Sperm does not contain any mitochondria, so we inherit them from our mothers. A mom may have a percentage of mutant mitochondria present, and the mitochondria all get randomly selected into egg cells. A single egg cell can contain normal mitochondria and mutant mitochondria. The balance between the two will determine the cell's health. This is why symptoms of mitochondrial disease varies between people, even between members of the same family. Disease can be severe and start at birth, or be mild and not detected until adulthood. Sometimes the disease can even present itself suddenly when sick with another illness because of the stress the body is under while fighting this illness or infection. Mitochondrial disease is not a single disorder, but a term for many disorders in which the cells cannot produce energy. Therefore, multi-organ involvement is typical. Mitochondrial disorders affect between 1 in 6,000 and 1 in 8,000 live births. And here is a list of just a handful of mitochondrial disorders, particularly ones that I will be talking about today. Or mentioning rather, and of course there are many, many others. GI manifestations often present before other mitochondrial disease symptoms. They are typically pretty nonspecific, so symptoms such as reflux, vomiting, dysphagia or trouble swallowing, diarrhea, even constipation, delayed gastric emptying, also known as gastroparesis, feeding difficulties, and abdominal pain. But there are a few very specific symptoms that can be presented in very specific syndromes. So pancreatic insufficiency is seen in Pearson-Mero syndrome, and GI dysmotility is seen in Minji. So we'll start off with reflux and feeding difficulties. Upper GI symptoms are actually pretty common in mitochondrial diseases. And in a very small pediatric case series, there were only 6 patients that were enrolled in this case series, but they all had poor suck, feeding refusal, and choking within the first few weeks of life. Later in childhood, they were found to have distant symptoms and even food aversion or food refusal. And that can lead to failure to thrive or poor weight gain, which is also a common finding in mitochondrial disorders. Leigh syndrome patients can have vomiting and or dysphagia. And patients with Kearns-Sayre syndrome have swallowing difficulties or dysphagia. When a patient presents to the GI office with dysphagia or trouble swallowing, the typical workup usually entails imaging studies to help evaluate the anatomy to make sure there are not any abnormal twists and turns, an upper endoscopy or EGD to help evaluate the lining of the GI tract. But if those studies are normal and a patient still complains of difficulty, painful swallowing, then the next step would be what's called an esophageal manometry study. And the esophageal manometry study Good morning. My name is Shivani Gupta. The patient presents to the GI office with dysphagia or trouble swallowing. The typical workup usually entails imaging studies to help evaluate the anatomy to make sure there are not any abnormal twists and turns, an upper endoscopy or EGG to help evaluate the lining of the GI tract. But if those studies are normal and a patient still complains of difficulty, painful swallowing, then the next step would be to do what's called an esophageal manometry study. The esophageal manometry study entails a catheter going down the nose into the esophagus and down to the stomach, with the catheter being secured in place in the study beginning. The picture to the left shows an example of the esophageal manometry catheter. There are pressure sensors along the length of the catheter, a few centimeters apart. After the study begins, the patient is asked to swallow different consistencies. It begins with water or Gatorade, then moves to thicker consistencies such as pudding or applesauce, and then it moves to solid foods. And essentially what we are trying to do is almost mimic or recreate the symptoms that the patient complains of at home and see in real time what the esophagus and the sphincters are doing. This is an example of what an esophageal manometry study looks like. And to orient, the picture on the left is a normal swallow. So the bright blue color is no pressure at all. And as you increase as you go up in pressure, the colors will change based on the scale to the bottom of that picture. And so when you have your warmer colors, orange, reds, and purples, that indicates stronger contractions or higher pressure. The band going across the top of that picture is labeled the upper esophageal sphincter. And the bottom band, also labeled here as the esophagogastric junction, is also the lower esophageal sphincter. Below that is the stomach, and in between the two sphincters is the esophagus itself. And so when you are at rest and without swallowing, the sphincters are closed, and that is that green-yellow color that indicating that there is pressure, so the sphincters are closed. At the initiation of the swallow, the sphincters open and the pressure drops, and so that's why both of those turns go. And then that's where you see a very nice, normal, strong esophageal contraction. The picture to the right shows what's called cricopharyngeal achalasia. The cricopharyngeus muscle is part of the upper esophageal sphincter, and achalasia means that there is incomplete relaxation of that sphincter in particular. And I show this because cricopharyngeal achalasia can be seen in patients with mitochondrial disorders. And you can see that if you compare the two pictures, right at the upper esophageal sphincter, that the picture to the right has a very high pressure, red, almost purple, compared to what is normal on the left. And these patients who have cricopharyngeal achalasia will complain of difficulty swallowing, vomiting, and things like that, even aspiration pneumonia. And I bring up aspiration pneumonia because it's considered one of the main causes of death in mitochondrial disease. So swallowing function should be examined routinely in patients, especially if symptoms are persistent or progressing. And so how do you treat reflux or swallowing difficulties? You may use antibiotics such as omeprazole, Pepcid, Tums. you can use prokinetic therapy medications, which are a group of medications that help speed up the contractions of the GI tract or help the GI tract move things along. And some patients may need some nutritional support. Some patients with swallowing difficulties may be able to tolerate liquids. And so that nutritional support for them may look like those shakes, Ensures or Pediasure or other formulas, but may also mean that a patient needs a feeding tube, whether that's an NG tube, NJ tube, or even a G tube that's surgically placed into the stomach. Another common symptom of mitochondrial disorders is vomiting. Cyclic vomiting is one specific kind of vomits, especially common in MELAS syndrome. Cyclic vomiting is a clinical diagnosis in which a patient will have very discrete episodes of vomiting, and it can last a few hours up to a few days. And the longer the episode lasts, the greater risk the patient is of severe dehydration and in admission to the hospital. In between the episodes, the patient is completely back at baseline. There may be other patterns of vomiting that also occur in mitochondrial disorders, and I have a few listed here. And vomiting is treated using anti-nausea medications such as Zofran, Phenergan, for example. For cyclic vomiting syndrome, these anti-nausea medications are used as abortive medications. So I tell patients, if you feel that you are not feeling well or you're starting to feel nauseous, you feel like an episode is about to begin, then start taking your anti-nausea medications. However, some patients have very frequent episodes, and they could be just a few days apart or even just a couple, week or two apart. In those instances, especially with the more severe cases, they may be started on maintenance medication to help prevent the episodes from occurring at all, or at least decreasing their frequency. There have been studies that have described gastroparesis or delayed gastric emptying in patients with mitochondrial disorders. The most common way to diagnose gastroparesis is with a gastric emptying scan. During a gastric emptying scan, a patient will ingest eggs and post that have the tracer in it. And about every 30 minutes to an hour, for up to 4 hours, imaging studies are taken, and the amount of food retention in the stomach at those time intervals are evaluated. So if somebody has over 60% of retained food at 2 hours and over 10% of food retained at 4 hours, that is considered abnormal. I will say that I feel like a gastric emptying scan is really that moment, that particular moment. And so I've had patients that have had normal gastric emptying scans, but have very clear symptoms of delayed gastric emptying. And so I do treat them as such. So just because you may have a normal gastric emptying scan does not mean that treatment for possible delayed gastric emptying may not be helpful. And talking about how to treat gastroparesis, so we start with our prokinetics again, so medications that help the stomach actually contract. Erythromycin and azithromycin are actually antibiotics that are not commonly used anymore, but they can work well in helping the stomach contract. Cyproheptadine is also called Periactin. It is an antihistamine medication that can help with relaxation or accommodation of the stomach so that it can help hold on to more food. Pyridostigmine and prucalopride are somewhat newer motility medications that also help the stomach contract, but not just the stomach, other parts of the GI tract as well. I usually exhaust all of my medication options before I move forward to more invasive therapies, one of which includes Botox. So interestingly enough, there are several places in the GI tract in which Botox can be injected. And the pylorus muscle is one of those. The pylorus muscle is the muscle at the end of the stomach that connects to the first part of the small intestine. And sometimes that muscle can be spastic or not relax entirely, which can lead to nausea, vomiting. And so by injecting Botox into that muscle, it ideally should help relax the muscle and help relieve some of these symptoms. Botox lasts about 3 months. And so, the onset of action can be about a week or so. So I usually give patients the first few weeks after an injection to see if it's going to be helpful for them. But unfortunately, it doesn't work for everybody. And if that's the case, then the next step is to move forward with a gastric stimulator. And so just very briefly about the gastric stimulator. So the stomach actually contracts at about 3 times per minute. When somebody has delayed gastric emptying or gastroparesis, you have very uncoordinated and disorganized contractions. And so when a gastric stimulator is implanted into the abdomen, it sort of shocks the stomach and helps make those contractions more organized again. The gastric stimulator is implanted into the abdomen. However, prior to that happening, we do a trial for about 2 weeks to make sure that the patient will actually benefit from it. The anti-duodenal manometry study is another study that can be done for patients that have persistent abdominal pain, nausea, vomiting, and feeding intolerance. The picture to the left shows an example of an intraduodenal manometry catheter. Similar to the esophageal manometry catheter, it has pressure sensors along its length every few centimeters apart. And as the name of the study suggests, the antrum is the last part of the stomach and the duodenum is the first part of the small intestine. And so that is exactly the areas of the GI tract that are being assessed with an intraduodenal manometry. And some patients that have mitochondrial disorders may have neuropathic or nerve abnormalities that can be seen in this type of study. They may have absent contractions in the small intestine. They may have abnormal contraction in the stomach after eating, which would suggest gastroparesis and of the like. So moving on down of the GI tract, diarrhea can also be a common symptom in mitochondrial disorders. And this is a result of possibly intestinal overactivity, exocrine pancreatic insufficiency, which we'll talk about here shortly, but essentially it occurs when the pancreas is not able to produce enough of the digestive enzymes, and so therefore can cause diarrhea. Small intestinal overgrowth essentially is when you have bacteria in your small intestine that is overgrown, as the name suggests, and especially seen in MIDD and MNG. And so when we think about treatment of the diarrhea, if we're talking about the intestinal overactivity, so that means that there are many spasms or cramps or just a lot of movement of the intestine. And so we have to think of ways to slow it down. And so the most common medication that most of us are aware of is Imodium to help slow things down, to help stop those significant bowel movements. And Lomotil is another example of a medication that can help slow the bowel down. And Leptin and Bentyl are antispasmodic medications. They're often used for patients that have almost IBS-like symptoms, which essentially can also be considered intestinal overactivity, and so can potentially be helpful here as well. In exocrine pancreatic insufficiency, the treatment is to replace those digestive enzymes that the pancreas is not able to produce. And then antibiotics are used to treat small intestinal bacterial overgrowth. Constipation is a common symptom in mitochondrial disorders, and it's a result of the GI dysmotility, especially seen in MELAS, MDD, and the POLG1 mutation. So when I think about treatment of constipation, I like to think about it in categories of the types of medications that can be used. One big one are osmotic laxatives or softener medications. The most effective and most common softener medication that's used is Miralax. You can use magnesium in the form of magnesium citrate or milk of magnesia. And lactulose is another softener medication that's used for patients that can't tolerate Miralax or opt to not use it, or for infants before the ability to use Miralax. The other type of category of medications that I'd like to highlight are the stimulant laxatives. So they actually help the colon squeeze. And I usually tell families that the reason that I usually like both types of medications is because not only do you need a softener medication, but you also need help with actually stimulating the colon to squeeze, contract, and get the stool out. The reason behind that is because when you have struggles with chronic constipation for many years, the colon has to stretch out and dilate to accommodate the stool that's being held onto. And when that occurs, the muscle fibers of the colon cannot meet and therefore can't contract the way we would expect it to. So that's where the stimulant medications are helpful. So medications such as Senna and Bisacodyl can be helpful in addition to Miralax, for example. And I have found that using both types of medications at the same time for 6 months, a year, whatever it takes for that particular patient can be very, very helpful and has been most successful. There have been some newer medications that you may have seen commercials for, Amitiza being one, and linaclotide or Linzess being the other. And these medications can be somewhat difficult to get approved through the insurance because at first they were not FDA approved in pediatrics. However, linaclotide or Linzess has been recently approved for ages 6 years and older, so that has been a much more convenient option for us. I'd like to take a second to just put in a plug for this video that Children's Hospital of Colorado have made called The Poo in You. And it's made so that families and patients and even children can understand the process of chronic constipation and how to treat it. And so I do encourage my patients who have chronic constipation to watch it. So if medications have not been helpful, and again, you've tried several different kinds and different conditions and different doses, and nothing seems to be effective or seem to really give much improvement, then there are other workup studies that can be done, one of which is called the SITS marker test. And essentially what it does is it helps test the colon to see how well the colon actually moves, contracts, and functions. The picture to the left shows an example of a capsule. And in that capsule, there are 24 markers. The capsule is ingested by the patient, and if they can't swallow the capsule, then it can be opened and sprinkled onto food. And 5 days after the ingestion of the markers, an X-ray is taken. By that time, you would expect all of the markers to either be out or have a few retained in the rectum, but nowhere else in the colon. So the picture in the middle, in the 3 panels on the right, would be an abnormal study because you see the markers kind of scattered throughout the colon, and which would indicate that there is possibly some GI colonic dysmotility. When I have a patient that has an abnormal SITS marker test, doesn't give specific details as to what those contractions look like. Are there any contractions that are going through the area that may be abnormal? And are they just not strong enough, for example? So the next step at that point, if you have an abnormal SITS marker study, is to do what's called a colonic manometry study. And the catheter looks very similar to the esophageal catheter, and the intraduodenal catheter is just much longer to accommodate the length of the colon. The catheter is typically maybe a colonoscopy, so that's the picture to the far left. You see a picture, this is during a colonoscopy where the catheter is being placed. Following placement, you can get an X-ray to determine kind of where the catheter is and that it's in the correct position. And then the picture to the right shows the same color scheme or similar color scheme to, again, the other manometry studies that I have previously mentioned. And this study lasts about 6 to 8 hours, so it does last a while, and it is exhausting for the patient. However, it gives a lot of very important detailed information of what those contractions look like through the colon, and do they have them at all. And so the picture to the right shows, again, that bright blue color, which is no pressure, and with the reds and purples, meaning higher pressure or stronger contractions. And you can see here that all the way from the cecum, which is the first part of the colon, all the way to the rectum, this particular patient had very strong normal contractions. However, in a patient with chronic constipation, they can have areas where the contractions don't go through that. And that is typically seen in the distal part or the low end part of the colon. And if that is the case, let's say we have a patient that has an abnormal motility in the lower part of the colon, and medications are not enough to overcome that area, then what do we do in terms of treatment? A patient may have what's called a Malone appendectomy or cecostomy placed with our surgical colleagues. And an appendicostomy is when the appendix is brought up to the belly button, and then a small tube similar to a G tube is placed, and that allows the families and patient to be able to flush the entire colon out from beginning to end using medications. And it ensures that the colon is completely empty, which is especially important in treating chronic constipation, because the more the colon is emptied on a regular basis, the more likely the colon will return to its normal size and regain its function. So this has been a game changer or life changer for many patients, and does not even have to be anything that's permanent. After about a year or so of its use successfully and being on a good flush regimen, a lot of patients' constipation actually improves quite a bit. Pseudo-obstruction is another GI manifestation of mitochondrial disorders, where you have poor intestinal propulsion or force. They have signs or symptoms of intestinal obstruction, but no physical obstruction found within the intestine. Patients will typically have abdominal pain, abdominal distension or bloating, vomiting, eating intolerance. Typically, patients will have imaging studies that show air fluid levels, which means that the colon is not contracting well, or intestinal dilation, again, in the absence of a mechanical obstruction. The X-ray to the left shows a normal X-ray, and you may be able to appreciate that this area here that I'm circling with the laser pointer is the colon, and you can appreciate the size of it. However, the picture to the right shows that the colon is extremely dilated, which I will highlight here with the pointer. And patients that have X-rays that are like this are concerning for a possible obstruction. Pseudo-obstruction is seen in patients with Meningi and MELAS. And so what happens in pseudo-obstruction or GI dysmotility disorders in general? The GI tract has two plexuses, the myenteric plexus and the submucosal plexus, which is a plexus of nerves that helps control parts of the colon. And the submucosal plexus is really in charge of blood flow, secretion, things like that. The myenteric plexus nerves help the muscles of the GI tract actually contract. So in mitochondrial disorders, you may have degeneration of these areas in the myenteric plexus that then will affect the muscles of the GI tract. The treatment for pseudo-obstruction is supportive. So you can use some medications such as acid-blocking medications, some pro-motility agents, and some supplements. The nutritional support aspect of things, so some patients can't tolerate any food or drinks in their GI tract. When that's the case, the patient may need to be on TPN, which is nutrition through an IV. The patient may also need what's called a G tube, which is a feeding tube that's placed directly into the stomach, or a GJ tube, which starts in the stomach, and then there's an extending tube that goes through the stomach and down into the intestine, the small intestine. Exocrine pancreatic function occurs when the pancreas does not make enough digestive enzymes. When that happens, the patient can have bloating, gas, and diarrhea. Pearson-Marrow pancreas syndrome is the particular syndrome in which they have exocrine pancreatic insufficiency. The pancreas will have scarring and look atrophied or like it's wasting away. Treatment of EPI is by giving those enzymes that the pancreas is not able to produce, putting the patient on a high-fat diet, and replacing vitamins. Patients with mitochondrial disorders can also develop pancreatitis. It has a pretty good prognosis and usually recover. However, there is a high chance of recurrence. And liver disease, like we mentioned at the very beginning of this talk, has hundreds to thousands of mitochondria. Therefore, liver disease can be very common in mitochondrial disorders. The earlier the patient presents with liver disease, unfortunately, the more severe it is. So in infants, they're likely to present with liver failure, but older children will likely have a slower onset, and eventually it will lead to chronic liver disease, but not necessarily present with chronic liver failure, acute liver failure. Patients who have POLG1 mutation can often have liver disease. In children, liver failure comes before neurological symptoms. They may also have reflux and vomiting as presenting symptoms. And when you look at the liver, you see infiltrations of fat and cirrhosis or scarring. And that is the picture here at the bottom of the slide. The picture to the left is a normal liver, and the picture on the right shows a liver that's been scarred and therefore does not function appropriately. Pearson syndrome not only affects the pancreas, but the liver as well. And some patients advance to cirrhosis or scarring by even 4 years of age. Navajo neurohepatopathy occurs in Navajo children. And there are several different forms of liver disease that these children can have. But again, earlier presentation can mean more severe and likely fatal. In summary, there are many GI manifestations that can be a part of mitochondrial disorders. Most of them, again, are vague, nonspecific, but there can be more specific manifestations depending on the type of disorder. It is important for GI providers to consider mitochondrial disorder in patients with persistent GI symptoms, since the GI symptoms can be the first manifestations of a mitochondrial disorder. So it's something to always keep in mind. And treatment for really any of these manifestations is supportive. Again, I would like to thank the foundation for inviting me to speak with you, and I appreciate everybody taking their time to listen to this talk. I hope it was helpful and informative, and now we will open up the floor for questions. Thank you very much.